Good afternoon. My name is Liz Deers. I'm Senior Vice President for Legislative and Regulatory Affairs at the Medical Society of the State of New York. And I'd like to welcome each of you to MSSNY's Advocacy Matters program. Advocacy Matters is a one-hour continuing medical education webinar series that is held on the second Tuesday of each month. This initiative is sponsored by MSSNY's Legislative and Physician Advocacy Committee and is designed to enhance communication with physicians across New York State concerning topical and timely issues of significant interest to physicians and their patients. Elected officials, agency officials, and key legislators and their staff will be invited to discuss regulatory and legislative matters. Today's webinar will provide each participant with 1 hour of continuing medical education credit and will go from 12:30 to 1:30. At the end of the program, you will be asked to complete a CME evaluation of today's speakers. The evaluation will be posted at the end of the webinar for each participant to complete. Your CME certificate will be emailed to you within the month. You will be muted for the didactic part of the presentation. Save your questions for the question and answer period at the end of the program. To ask a question, you may either raise the hand located in the box to the right of the PowerPoint or send us a question via the chat. Please remember to put your hand back down when your question is being answered. For CME accreditation purposes, let me state that neither I nor Todd Askew has a financial interest in any portion of today's program. The program today is entitled Federal Legislative Update. We are fortunate to be joined today by Todd Askew, Director, Congressional Affairs for the American Medical Association. Todd Askew is the Director of the Division of Congressional Affairs, a position he has held since 2006. In that capacity, Todd oversees the AMA's team of congressional lobbyists and develops and implements strategies to advance organized medicine's priorities before the United States Congress. Todd, we welcome you to our program today and look forward to hearing your presentation.
Thanks very much. I appreciate the opportunity to speak to everyone and share a little bit of information about what is or is not happening here in Washington. Obviously, the main thing I'm going to focus on is the ongoing battle to replace the SGR and reform the way Medicare physician payments are made. I also mentioned a few related issues related to a regulatory relief agenda that's coming together. As you know, there's been a renewed interest in Washington since the beginning of the year on repealing the SGR and replacing it with a new system of Medicare physician payments that focus more on value and quality as opposed to volume. All in Washington, everybody on Capitol Hill agrees that the sustainable growth rate formula is a failed policy. We had warned Congress of this in 1997 when it was first enacted. Congress has, since it started to fall apart in 2002, responded with temporary patches that you know have not kept up, even close to keeping up with the cost of providing care. Everyone is on the same page now, finally, with some real interest in getting this done this year. I would say there's two reasons that you have this renewed interest in repealing the SGR. The first of all was a bit of good news that we got from the Congressional Budget Office. The CBO scores or puts a price on each piece of legislation. Previously, the cost of repealing the SGR has been estimated to be $270 billion over a period of 10 years. CBO came out with a new score after evaluating new data on the slowing of Medicare cost growth, and now says that repealing the SGR would cost $138 billion, so about half of the previous score. The chairman of MedPAC has commented that the SGR is now on sale, and Congress should take the opportunity before CBO changes its mind and raises the cost again. The second part, I think, that is really driving the interest in repealing the SGR now is increasing pressure from other providers. Each year that Congress patches the SGR and just kind of kicks those cuts to the next year, they do have to pay a substantial amount in order to put a freeze or small increase into place. This past year, the cost was $25 billion just for a one-year patch that froze payment rates for 2013. Most of those dollars have to be paid for, and Congress has been paying for them by making cuts to other Medicare providers. This year, the hospitals received cuts of $15 billion as a contribution, if you will, to replacing or to patching the SGR for 1 year. The low-hanging fruit, if you will, has pretty much been used, and the decisions that Congress is having to make to cut other providers are becoming harder and harder to build consensus around. They would very much like to get out of this pattern of, at the end of every year, having to pick winners and losers and cut what other providers are going to get in order to pay for the patch. So beginning early this year, the two committees of jurisdiction in the House of Representatives, the Ways and Means Committee chaired by Dave Camp of Michigan, and the Energy and Commerce Committee chaired by Fred Upton, also of Michigan, put together, and we're talking about the majority staff here, the Republican staff, an outline of a proposal that they would like to move forward sometime this year. In the last couple of days, they have, after receiving a good deal of feedback from the physician community, they've put together a revised proposal with a little bit more detail that shows the direction that they would like to head. This is not a legislative vehicle yet. There are a lot of details that are lacking, but I do want to go over with you basically the structure that they are anticipating moving forward, and I'll mention a couple of initial concerns that we have. First of all, the proposal is pretty consistent with what the AMA and others in organized medicine have been pushing for the last few years. It would essentially repeal the SGR upfront and provide a period of stable payments for a number of years. These payments would be locked into statute. They wouldn't be subject to a formula. We would obviously be arguing for increases each of these years, but it would allow some time for both the Center of Medicare and Medicaid Services as well as physicians to prepare for new payment models that would be utilized for Medicare beneficiaries. After that period of time, what the committee envisions doing is, in part, under the current fee-for-service system, providing two basic rates. One, there would be a base rate that all providers would receive. Secondly, there would be additional dollars that could be earned for participating in one of several ways regarding quality reporting of measures. The quality scores from these reporting would be either judged, compare physicians to their peers, or measure improvement from 1 year to the next. Success in those two areas would mean additional payments for the physicians, though the mechanism for delivering those payments has not been spelled out. The quality measures would be risk adjusted so that the severity of illness of patients would not cause a penalty for physicians. And providers would be able to choose whether the assessment of quality occurs at the individual level or at the physician group practice level. CMS, or rather the committee staff, is very cognizant of the burdens created by these reporting programs, and they have identified several things they would like to do to streamline those burdens, such as making these measures reportable through electronic health records, patient registries, or other data sources, and bringing into alignment the myriad of other reporting programs that they've imposed over the past few years such as the PQRS program, and also aligning where possible with private payer initiatives so that a larger portion of a patient population would be subject to the same measurement. You wouldn't be participating in different programs for different payers. Another tool that they are contemplating that we have been pushing very hard and is absolutely critical is timely feedback so that providers will know where they stand. Currently, if you're aware, in the PQRS program, the data is not available till well after the period of participation. You have no idea how you did or whether or not you qualify for a bonus payment. We believe that the data should be available real time so that you can check from time to time and understand whether or not you're taking the steps necessary to earn additional payments, or you can identify those steps that you need to take. CMS has said that they don't have the capacity to provide real-time data, and that might be true, but it's not a question of technical capability, it's a question of resources. There are several private payers in the country running quality improvement programs that allow physicians to look at their data in real time so that they can assess where they stand, and we think certainly that should be a portion of any type of program that is implemented in Medicare. As for the quality measures themselves, the committee staff is very aware of the fact that there are a lot of measures out there that just are not good. They're not valid, and they believe that the quality measures that physicians should report should come from the physicians. It should come from the physician specialties, and that is the route where they anticipate those measures being developed. The physician specialties could submit the measures to the National Quality Forum for endorsement, as is currently the practice, or because there are some capacity concerns within QF, they could, if they meet certain requirements, submit them to the Secretary, and the Secretary would be required to adopt the measures directly. These measures would do things like meaningfully differentiate performance or address at least one of the following domains: clinical care, safety, care coordination, or patient and caregiver experience. One concern that we have with this approach is that there are clearly areas where there is no documented meaningful gap in the quality of care. By that I mean quality of care is good in many areas, and it seems overly burdensome and a bit silly, quite frankly, to be reporting quality measures where we already know the quality is high. Because of that, there is a third option that it appears from the documents from the committee that providers would be able to pursue. Rather than reporting quality measures, they would be allowed to participate in clinical practice improvement activities. Some of the examples that the committee has provided are using decision support tools, improved organization or coordination of care delivery, or the utilization of patient registries for targeted chronic conditions. In this way, we believe the committee intends to provide the credit, if you will, for quality improvement to those practices who participate in items like that, in activities such as those, rather than simply reporting quality measures. The committee has suggested that clinical quality measures be updated every year. I think, unfortunately, this shows a little bit of lack of knowledge from those in the committee at this time on the task, the difficult task that is pulling quality measures together. These are processes that take years. They're generally reevaluated on a 3 to 5 year basis as new evidence becomes available. But we believe that it should be a longer time for updating these measures. Obviously, though, as new measures become available, they should be able to be added at any time. The Secretary is also aware that many specialties do not possess the capability or the resources to produce valid quality measures. meaningful quality measures, and so we will be pushing very hard that resources be provided to those that would develop the measures. The committee also anticipates that in a third phase, at some time down the road, physicians who are successfully providing care that's measured high on the scale in phase 2, that they would also have further opportunity to earn monies by demonstrating increased efficiency in the provision of care. I think we have to be very careful in this, in that it doesn't become an incentive to withhold care. We frequently know that more care or better targeted care provided in the ambulatory setting can save money for the healthcare system as a whole in reduced hospitalizations or better management of chronic diseases. However, it could come across on the balance sheet as inefficient care if you look only at the silo of services provided by the physician. And so that's something that the committee is going to have to take into account. Much like the proposal that the AMA has talked about with most of the state medical associations and also with the specialties, you would be able to opt out of all this reporting if you participated in an alternative payment program. Though it's not very well defined in the legislation, in the proposal, we expect things like accountable care organizations or primary care medical homes, certain bundling or gain sharing arrangements, other types of perhaps disease-specific capitation. Physicians participating in those alternative payment models would not be required to participate in the quality reporting or clinical improvement activities in order to receive additional payments. There's going to have to be some work done to determine the threshold for the number of patients that would have to be part of an ACO or a more tightly defined alternative model like bundling, but that's some of the work that the committee still has to do. Lastly, as part of this proposal, the committee is taking a broad look at the burdens that the current payment system and other administrative requirements place on physicians. I think there's a strong belief among many of the committee members that physicians face needless expenses reporting or participating in certain programs that many are overly burdensome and take up too much time relative to the value they provide. So there's an opportunity here to move some significant regulatory relief in tandem with this proposal. We've identified a number of areas where we believe regulatory relief should be provided, and I'd like to mention a few of those now. The first is simply administrative simplification. Payers have a multitude of different ways they require their physicians to perform different tasks. We believe that there should be uniform standards adopted, uniformity in the way physicians enroll with payers, the way physicians sign up with payers to perform certain business functions, such as sending claims, a uniform way for physicians to access the payer's contracted fee schedule, as well as a uniform way for single claim code edits that are used across all payers rather than these black box edits that differ between all payers, and a way to let physicians know whether their claims and other transactions were actually received. All of these things are performed differently by different payers, and we believe uniformity could produce significant administrative savings. We'd also like to see some modifications in the Meaningful Use program that incentivizes physicians to implement electronic health records. We believe that the fact that under the current program you have to meet 100% of the requirements in order to be successful is not appropriate, that there should be some prorated option for you're only able to meet 7 out of 10 requirements, you should still receive some payment rather than having all the work you've done to receive payments go for nothing. We believe that there needs to be an independent evaluation of the current Meaningful Use program before the additional phases 2 and 3 of Meaningful Use are fully implemented. And we believe that those requirements, reporting requirements that are not relative to a physician's practice should not be required for those particular physicians. And a psychiatrist being required to take a patient's blood pressure, for instance, or BMI, might not be appropriate, and those should not be, obviously not be required in order to meet meaningful use. We'd also like to see the extension of the safe harbor that allows hospitals to provide health information technology to physicians. There has been some news on that in the last couple of days. Though it's due to expire at the end of this year, CMS has proposed extending it perhaps to 2016, which coincides with the sunset of the Meaningful Use program for Medicare, or perhaps as long as 2021, which coincides with the sunset of the Meaningful Use program under Medicaid. We all know that ICD-10 is a significant burden that physicians are facing, and while we have been successful in delaying the implementation of ICD-10, it's unlikely, it seems, that we'll be able to continue to hold off. We believe that the phase-in implementation of ICD-10 should be phased in, beginning with the inpatient setting first, that there needs to be significant resources invested in education and support for implementation of ICD-10 in physician offices. We also believe that many of the current programs that are out there, such as the PQRS, the Quality Reporting System, or the Value-Based Modifier, which is a budget-neutral adjustment to all payments that will be made beginning next year with larger groups, and then coming years down to individual physician level. These things need to be reevaluated. They need to be coordinated so that we're not facing multiple different deadlines for multiple different programs. CMS needs a significant technology upgrade in order to provide more rapid feedback to physicians. And we don't believe that the penalty should be based on a performance period that precedes the penalty year by more than 3 months. You shouldn't be able to find out a year later that your measures weren't correct and then face a penalty when you had no opportunity to correct mid-course. On fraud and abuse, we believe significant work needs to be done to rein in the RACs. We believe that the RACs should face penalties for poor contractor performance, that multiple and duplicative programs in the fraud and abuse arena need to be better coordinated so that we're not having the same claims face multiple audits. And we also need to make sure that the Medicare advisory contractors, or the MACs, provide more education and outreach to physicians. There are a number of other regulatory improvements that I think we can pursue in the context of this proposal, but that is a brief overview of the direction the House is looking. Essentially, maintaining fee-for-service, but requiring quality reporting or other activities in order to receive a full payment, and then also allowing folks that participate in alternative models to opt out. I just want to mention a couple of other very quick issues that we're facing here that we're going to see significant congressional interest in. The main one is the problem of drug diversion, specifically with opioids, and trying to find that balance between the needs of patients and the potential that the drugs have for abuse. The AMA believes that we should fully fund the prescription drug monitoring programs. They're an important tool, and people at all levels of the drug distribution chain need to be responsible for making sure that these drugs are being properly prescribed and also properly distributed. There is right now a major push in Washington to reschedule hydrocodone products to make them more difficult to prescribe. However, there's a significant problem with nursing home patients in that physicians can't phone in the Schedule II meds, so you could have nursing home patients who can spend a day or two without access to pain relief. We're working on a solution to that should they reschedule the hydrocodone products, but Congress is really on a tear, and they're targeting physicians, they're targeting pharmacists, they're targeting drug manufacturers to be more responsible in the way that hydrocodone and other similar products are used. We want to make sure that this gets done in a responsible way and not a way that's simply, as some drug stores have already started to do, imposing seemingly random limits on the amount of opioids that can be prescribed, the number of tablets, not the actual strength of the tablets, but they're limiting the number of tablets. We also see some major chain drug stores refusing to fill these prescriptions for those who don't have insurance, fearing that there's a higher risk of diversion for the cash paying patients. So that is another activity that we're going to be concentrating on here. You know, all of these activities and many more, and I hope you'll take a look at the AMA website advocacy section so you can become more aware of many of the issues that we're working on. All of these activities, in all of them, it's important that physicians' voices be heard. We can go up to Capitol Hill and lobby and testify and write letters, but it's really the folks back home, it's the constituents of the lawmakers that they listen to the most, and especially as physicians, the amount of respect that you command when discussing these issues is considerable. So I hope that you will take time to call or write your members of Congress, or when they're home during congressional recess periods, to go by and visit them in their district offices and share with them your thoughts and concerns with the direction some of these programs are going. And with that, I guess I'll wrap up, and I'd be happy to take any questions on any of these issues, or I'm happy to try to answer questions on any other topic you might have.
Todd, thank you. This is Liz Deers. Thank you so very much for a very comprehensive and well-articulated presentation. You certainly have a lot of work that you're moving forward with, and we very much appreciate that you took time today to be with us. I'm going to throw this out to the attendees, the audience. Are there any questions from physicians who are on the phone? Okay, while we're waiting for physician questions, I'm going to turn over to Mo Oster, who I know you know and has developed a list of questions that he has for you, Todd. So, Mo?
Todd, I very much appreciate this. Is a very, very comprehensive update. And just while we're waiting for some questions to come up, I guess I would ask you first on a general question, are there specific points that the physicians should be saying, that you're suggesting that the physicians should be saying with their members of Congress as it relates to repeal of SGR, as it relates to changing around, these proposals to change the Medicare payment methodology?
Sure. I mean, Mo, I think there are a couple of important points that I think folks should make when they're talking to their legislators. One is, first of all, obviously it's time to get rid of this thing. It's a total failure. We spend billions of dollars every year just to produce a freeze, and in return get a bigger problem the next year. It's been going on for a decade, and it's incomprehensible that Congress has not addressed this yet. It's important that when we talk to our legislators on these proposals that we emphasize that essentially physician payment rates have been flat for the last decade. They're 2% higher than they were in 2002, which makes the federal government, Medicare in particular, a terrible business partner for physicians. And the uncertainty that comes with these annual last-minute fixes leaves physicians wary about making investments in their practice. We know that healthcare is changing rapidly, and that the increasing role of information technology and data in improving care and care coordination, transitions in care, is so important that physicians have to make these investments, but it's difficult to do with the payment future so uncertain. I would say that any new payment system absolutely has to provide physicians with some predictability about what the payment rates will be that year for the coming years. We've heard a lot during the tax debates that small business owners need to know what their tax rates will be so they can plan accordingly. Well, physicians need to know what their revenue is going to be in order to plan accordingly and make the investments that are needed. And lastly, I would say emphasize that we need to get a handle on some of these overly burdensome and ridiculous reporting requirements. That if we're going to have new reporting requirements, they need to replace current reporting requirements, not add to them. And that physicians are willing to engage in new ways of delivering care but not without a good, solid partner in the Medicare program, and that's not something we have right now.
Thanks, Todd. Another question I'd ask as well, too, is just what do you think the prospects are of achieving some type of long-term SGR relief or repeal without having some type of change to the Medicare payment system?
Well, I would say that Congress is not interested in just dumping more money into a system that they see as rewarding only volume. And it does. There's no incentive. I mean, obviously physicians provide the highest quality care they're capable of, but that's not rewarded in the current payment system. And Congress wants to have the system focused on improving quality and, at the end of the day, improving value and reducing growth. So without physicians willing to engage in new ways of delivering care, and it's not delivering care, it's coordinating care, it's managing chronic conditions better. Unless physicians are willing to engage in those activities, there's not much interest in Congress in fixing it. Now, to the bigger question of the prospects of getting anything done, I mean, this is Congress after all, and the last 3 years, I think, have been the most gridlocked, unbelievable disaster that I've seen in my 20 years here in Washington. It is much of this they engage in partisan battle, seemingly just for the sake of partisanship. However, on the SGR, we do have agreements. Republicans and Democrats in the House and the Senate agree that we need to get rid of the SGR. So if there's anything that can overcome that gridlock, I think this is a good candidate for it. The other problem is money. It's $138 billion gets you a free, so it's probably going to cost a little more than that. And that's still a lot of money, even in Washington. And they will need to find a way to pay for it. I think the big concern that we may have is they'll come up with a good SGR replacement. They'll come up with a good policy that physicians can embrace, that beneficiaries can embrace, that folks agree will provide higher quality care at better value. But they'll then pair it up with a pay-for that's completely political and ideological. Medicare reforms are very much on the table, and I think there are some Medicare reforms structural to the program that could be gotten through. I think we'll see some of that in the president's budget. But it always seems like people want to go one step further. They want to put absolute conditions on some of these things, and that's a huge challenge. So while the environment is as good as it has ever been to getting this done, I'm not going to say to anybody that it is easy or a sure thing. There's a lot of work to be done, a lot of pressure to be brought on members of Congress, and a lot of compromises are going to be needed by folks on both sides of the aisle.
Let me just take this opportunity to remind those who are participating on this webinar program that you can ask a question. Please just go to the right side of your screen, raise your hand, or use the chat feature to send a question to us so that we might ask Todd on your behalf. So with that, let me just, Todd, can I just ask a question? I guess maybe this might be a little bit more detail-oriented than big picture, but I know from experience with the Adirondack Medical Home up here in New York that issues around, which measures to use and then how to attribute patients were really thorny issues. And can you provide any detail around how the framers of this construct are considering attribution of patients?
So I think in the House proposal as it stands now is not as focused at all on the alternative payment methodologies. It's more focused on reporting requirements to continue to participate in a fee-for-service-like system. I do know and completely agree that with some of the alternative models, particularly ACOs, attribution remains one of the most difficult issues. Certainly, it's no good to attribute it to just to the primary care provider or just to the patient's regular physician, particularly when the physician doesn't have any control over who else that patient sees. I would say that those in CMS who are working on the issue of ACOs are very well aware of the importance of this issue, particularly as it becomes a basis for payment in the future. I wish I could give you more details on what kind of progress has been made, but I can't do that right now.
Well, thanks. This is more later.
And I guess on the question as well is, anything specifically on the context of how long the phases might take place? I mean, how long is the period of SGR stability? There were 3 phases, if I recall correctly. There was a period of stability. Right. There was, while the new payments were being developed, or new criteria were being developed, and there was a period when it was based upon fee-for-service plus some type of other component, and then there would be a 3rd phase. Is any sense like how long each of those phases would occur based upon the proposal?
Well, they have given no details or indication. They are probably, my best guess is from working with the committee over the years, they're probably thinking 2 years. We believe that 3 to 5 years would be more appropriate. What has to happen is not only do the measures have to be adopted, but all the rulemaking, there's so many details that would have to be derived through regulation that it seems almost impossible that CMS could accomplish that in a 2-year period and provide physicians sufficient opportunities to get themselves ready to begin to participate. So we're pushing 3 to 5 years for a period of statutory updates whereby we would know what the updates will be going forward for that entire period. Now, in terms of those who may wish to engage in alternative models, certainly we think that as soon as those become available and as soon as physicians themselves are ready to participate, that opportunity should be available to them rather than having to wait till the end of that time period. In terms of what the committee thinks for Phase 2, when they would start reporting on clinical quality on quality measures or clinical improvement activities in order to receive an additional payment. I mean, they're thinking it will be a number of years, and it would essentially become more of a permanent part of the system. The efficiency part, that is what they see as their Phase 3, is very much less defined, and I think that they don't really have any idea when they would start making yet another opportunity for additional payments be available. And let me mention, since I mentioned this concept of additional payments, one thing that is very troubling about this proposal, which they have not put in paper, but we have confirmed in speaking with some of the committee staff, at this time, they intend to have essentially a withhold or a lower payment amount, and by participating in these activities, you earn your way back up to a full payment. We think that's absolutely unacceptable, that physicians, no other provider category faces something like that, that physicians as a base payment should receive positive updates regardless of participation in any other type of program, with participation in these other activities an opportunity to being an opportunity to provide additional payments, not in order to earn your way back up to what a full payment should be. So we're going to be pushing back very hard on that if they put it on paper, and we already are pushing back verbally with them, and that would be something that could derail this whole thing.
Understandably. So we have a question, and the question is, CMS is planning to audit EHR bonus winners before payment. Is the AMA aware of that, and do they have an opinion about that?
I personally do not work on the regulatory side, but I will be happy to pass that along to my colleague in our Federal Affairs Division, and we can get back to Mo, and perhaps Mo can pass the answer back to the questioner if that person's identifiable.
Yep, they are, and we can do that. So
okay, well,
thank you.
I will follow up on that shortly, and we'll get an answer back to Mo.
And then just a question. You referenced gridlock before, and this is a good example of the result of gridlock, the sequestration cuts. You know, we're beginning to see reports leaking out about the impacts of it. We're seeing things in New York, frankly, all across the country about the impacts to oncology and office-based oncology, and doctors being forced to send patients to hospitals for their oncology care. We're seeing reports now about health, Medicare Advantage plans saying they're going to cut doctors by 2% if the cuts aren't turned around. Is there any prospect at this point about sequestration being reversed in any way, or or any type of further changes, or is that basically subject to further? Is that also kind of dead for now?
Well, at the moment, no. But I will tell you, the only way, in our opinion, that sequestration gets looked at again is in the context of a much larger deal on the budget. The larger deal on the budget would probably include entitlement reforms. It would include significant tax reform, and it would include something on deficit reduction to replace those cuts. But I have to tell you, and it's unfortunate, that physicians, in fact, all Medicare providers that are facing sequestration or now experiencing sequestration, the cuts are limited to 2%. Most other discretionary programs, including the Defense Department, are subject to cuts in the 5 to 8 to 10% range. So if they were able to, for instance, have those cuts, let's say you only had to cut 3% from defense and 4% from other domestic discretionary spending, it would seem unlikely that physicians or other providers who are limited to a 2% cut would see their cuts pared back, because the cuts are already less than others are facing. I mean, I agree with you, Mo. Sequestration is the worst possible way that we can identify savings, because there's absolutely no prioritization. It's just simply across-the-board cuts. And the fact that Congress failed on multiple occasions to stop sequestration from happening is simply unbelievable. It was there because it's such a terrible option. Nobody thought they would be foolish enough to let it happen, and yet they did. And I think that really speaks to the type of gridlock we have. Now, as these cuts continue to trickle through, maybe you will see some targeted efforts. I think the oncology example and the way that the oncology drugs are paid for is a good example of maybe what Congress didn't realize they were getting into, and may want to come back with some targeted fixes. But for right now, I don't think there's any hope of doing it outside a more comprehensive deficit deal. And we'll see. The President's budget is going to come out tomorrow, and reportedly the budget's going to contain some significant concessions, including $400 billion in additional health care cuts, though we don't see much in the way of physician cuts. but there'll be some pretty devastating things in there. For example, the proposal is going to include some significant cuts to graduate medical education funding. And those type of things kind of may provide a basis for some negotiations over a larger deal. Certainly there are already talks going on around tax reform, but that would really be, I think, the greatest opportunity to ameliorate some of the sequestration cuts. Otherwise, we are stuck with these cuts for a decade.
Dr. Crawford, you've raised your hand. Would you like to ask your question, please?
Can you hear me?
Yes, we can.
Yes, I can.
Oh, okay. Well, these problems are very extensive. What I was thinking is, and I've heard many people say this, is why don't we plan, this is kind of out of the box, a two-tier healthcare system, one where it would be a Canadian rationed healthcare, where everyone would pay in, and it would be, bare bones, like up in Canada, and then the second tier would be private pay. So people could buy private insurance. And this is similar to, I think they have this in certain places in Europe. So what I'm saying is, why don't we ask a new question rather than just take what the bureaucrats give us? Maybe we can, sort of direct the conversation.
Dr. Crawford, you're certainly not the first physician that I've heard say that and propose that to me. I think that from the AMA's perspective, we have policy against that type of system, and I'm bound essentially we're bound to advocate on the policies adopted by the House of Delegates. I think that, for us to change our position, we would have to get those marching orders from the House of Delegates through the normal policy development process.
Yeah,
there's certainly members of Congress who feel the same way. So
yeah.
it's a completely valid question, but it's not a direction that right now the AMA can go.
I think one of the problems from a doctor's point of view, of course, is the total disruption of the patient-doctor relationship, which really gives all physicians the reward for doing what we do. And I think if we completely let the bureaucrats and government regulators, businessmen take over healthcare, there'll be no reason to go into medicine. I mean, you might as well go into any other business. So, I'm very sorrowful about that, and I know all of us are.
And I feel like there are a lot of physicians who see the same thing you see and have decided to maybe go on the other end of the spectrum in terms of going into a cash-only practice or going into one of these concierge practices where essentially they feel like they have a more direct relationship with their patient, and for better or worse, they let the patient deal with the insurance company.
I mean, I feel so sorry for the doctors of the future. And I think the AMA should be very interested in the doctors of the future. And that includes the number one is probably the patient-doctor relationship. That's really all we have. And I think the AMA is completely failing us. So I want you to go back to the House of Delegates and tell them we need to protect the doctor-patient relationship, or else there's simply no reason to be a physician.
No, I think that sentiment is very strong within the House of Delegates.
Well, then do something.
Yes, and Todd, there certainly is a wide variety of perspectives among physicians. Like the AMA, I think MSNY has a wide array of perspectives of physicians about those who want on more sort of bring it back to like the physician and the patient with no government involvement, and others who want more government involvement in healthcare. And we're always trying to struggle to kind of find that balance as an advocacy organization. I know one of the concepts that was raised when we talked about the physician-patient relationship in Medicare and Patient Empowerment Act. That's certainly that physicians have supported across many different spectrums. Todd, is there any as all these discussions are taking place about changing Medicare payment formulas, any discussion about any prospects for enactment of the price bill?
Sure. Well, the price bill has been reintroduced. The Senate version has been introduced again by Senator Murkowski. This is, for those who might be familiar, this is essentially the private contracting legislation for Medicare patients. The committees in their documents that they've prepared outlining the proposals have requested comment. The AMA has supported Medicare Patient Empowerment Act inclusion as an alternative in a new Medicare payment system. They're certainly keeping it on the table right now. I am not as hopeful that it will stay in the mix as this product continues to develop, but I do think it's something that we'll continue to advocate for, including in any sort of new payment mechanism. In terms of moving it independently, I've seen no indication that there's a willingness right now in the House or the Senate to bring the bill up independently.
And I just want to make a reference point. The AMA has developed a lot of good background materials for doctors to use to help educate patients and local community leaders about the Patient Empowerment Act. It's on the My Patient, My Choice. If I get the website correct, My
Medicare, My Choice.
Yeah. Website, and we have also those materials on the MSNY website too. So, particularly for those physicians I know who have been very supportive of this issue in the past, they're good resources to kind of address some of the concerns that I think some senior groups have raised about the impact of the Medicare Patient Empowerment Act.
Well, Todd, we'd like to thank you very much again for taking the time to spend this hour with us. For those physicians on the phone, now is the time for you to complete the evaluation form. And let me remind you that our next Advocacy Matters program will be held on May 12th. We will have Keith Service, the director of the state's OPMC program, with us here in the office, and it looks to be a very interesting program. So thank you again, Todd, and thanks all for your participation today. Bye-bye.
Bye-bye. Thank you.